Okay, Dr. Angela Hanson is a geriatrician and Alzheimer's disease researcher who spends her days running clinical trials focused on Alzheimer's prevention, looking at things like diet and diabetes medications. She also works at the Memory and Brain Wellness Center and the Geriatric Consult Service at Harborview, where she applies her geriatric skills to caring for people with memory loss and to postoperative patients. She has incredible expertise to share with us on mixed dementia today. Thank you.
Thank you for that kind introduction, and thank you to the Northwest Geriatric Workforce Enhancement Center and all of its affiliates for inviting me to give this talk. So when I was invited to give this talk, I was a little puzzled actually because I thought, well, I haven't actually given a talk on this exact topic before, mixed dementia. But I'm a geriatrician, so I'm always dealing with and thinking about, and I'm immersed in mixed dementia. So I thought I could arise to the task. And so these are my learning objectives for today. And so I hope I will convince you that this is how we can, one way to approach mixed dementia or mixed cognitive impairment. And so these are my 4 objectives, a little ambitious. Oh, I'm going to start my timer here. So we have plenty of time for questions. So not all cognitive impairment is dementia. I'm going to go through the most common forms of dementia so that we can talk about how they might be mixed. We're going to talk about those mixed dementia pathologies and then discuss how the diagnosis of these different factors and diagnoses affects management. So we'll start with part 1. So not all cognitive impairment is dementia. And in true fashion, I really do believe as a geriatrician, working both in the inpatient and outpatient settings, that cognitive impairment is a geriatric syndrome. And I'll get into that on the next slide. But cognitive impairment, of course, is something that really matters to our patients. Of course, mentation is one of the 4 M's. Medications can certainly affect cognitive impairment, both in good and bad ways, and can affect mobility as well. So it's really a syndrome that encompasses the 4 M's quite heartily. And the contributors to cognitive impairment are a lot of overlapping circles, just like all geriatric syndromes. So you have the neurologic diseases that we think about, like Alzheimer's disease, Lewy body, and stroke, that can cause cognitive impairment or dementia. But there are a host of other factors that can cause or contribute to cognitive impairment. So medical diseases like diabetes, kidney disease, medications, either medications that we're prescribing for our patients like anticholinergics, or medications or substances that patients are using on their own like alcohol or marijuana. Psychiatric conditions, depression, poor sleep, and then finally, psychosocial supports or lack thereof. If a person loses their caregiver because they pass away or they move, that can unmask some cognitive impairment. One thing to think about is when we see somebody with cognitive impairment, we're worried about it. Of course, in the inpatient setting, this is drilled into, I think, all of us that care for anyone in the hospital or even in a nursing home. If someone has new onset cognitive impairment, you always want to worry about delirium. But this could also happen in clinic. So someone could present to you with prolonged delirium. Because as you may all know, delirium can take a while to resolve. If someone's been in the hospital for a while and you're meeting them for the first time, they could have prolonged delirium. And of course, it could be both. Sometimes delirium from a hip fracture or pneumonia is the first time a dementia patient is really presenting with their cognitive impairment. They have dementia, but it wasn't really known. They get delirious in the hospital, and now everyone is aware. And you may have all seen these diagnostic criteria for delirium. So delirium is really a condition that you diagnose clinically, and this is the kind of Sharon-Inouye method for diagnosing delirium. You need 1 and 2 and 3, or 1 and 2 and 4. So acute onset. So acute onset, but again, it can take a while to resolve. So it's kind of tricky if you're seeing the tail end. But acute onset, fluctuating course, and it's really marked by inattention, easily distractible, trouble paying attention. disorganized thinking, rambling conversations, illogical flow of ideas, and then altered level of consciousness. So you can see how a patient with maybe moderate stage Alzheimer's could kind of look like this, right? They might have trouble paying attention and they have disorganized thinking, but they shouldn't have an altered level of consciousness and it shouldn't be acute onset. So they can be distinguished, although it's not always super easy to do when you meet them for the first time. Um, and then, so you're seeing somebody with cognitive impairment, you're meeting them for the first time. Maybe it's mild memory loss. They have some mild memory concerns, or their daughter or son or niece or nephew has cognitive concerns about their loved one. What about, is it just normal aging? And this, of course, there's a wide variability in what normal aging is, both for physical and mental capacities. But there are some truisms about normal aging. There's a general slowing of cognitive performance, a decrease in mental flexibility, some difficulties in finding the right word. I feel like I'm starting to have this. Um, a mild decrease in short-term or working memory. So they have to write stuff down. But we should have intact memory for current events. We should be independent in our ADLs and IADLs if other things are not affected. And we do retain our verbal ability and our vocabulary, except for the occasional short-term or the word finding problem that I mentioned before. And we take advantage of this for neuropsych testing. Now, testing memory can be tricky because we do have changes in our perceptual systems and speed of processing. And that's normal aging also. So if you're going in there with a mocha and you're trying to do it really fast, and they're like, wait, what did you say? They could look cognitively impaired when we just have to slow down a little bit. Or similarly, I see this when I round with my residents when I'm on the inpatient service. They say 3 or 4 things in rapid succession to the patient. And I'm kind of like, now, what did they say about the findings? We just have to slow down a little bit with our people and make sure that they have time to process all of that stuff, especially when we're talking about really complicated information. This is just a graph showing you the variability in cognition, both at baseline and the trajectory of older people. So what we're looking at is a cognitive composite score from the health and retirement study of 500 older adults. And this is a cohort study. So people were measured over time. So they were started around age 60 and then followed over time as many times as they could. And what we're seeing here is you can just see the wide variety. Some people were scoring very high and not declining much. Some people were starting much lower. So everyone has different cognitive strengths and weaknesses at baseline. And then there's where'd my cursor go? A very slow, steady decline up until age 80. And then we kind of see a drop off, which is probably these people developing dementia potentially. They didn't have dementia at the onset. But again, we just want to see there's a wide variability in baseline and trajectory. But really, normal aging is marked by very, very slow decline. On the other hand, someone could present to you in clinic and have mild cognitive impairment. And so what is that? It's a little worse than normal aging, but not yet dementia. It's kind of this little bit of a nebulous category, but there are official ways that we kind of diagnose it in clinic. And it's problems with memory, language, judgment, and thinking, problems that are greater than expected for age, but less than required for dementia. They can still carry out everyday activities. So I think about people who have a lot more difficulty, they're having a lot more difficulty at work, but they're still able to work. Maybe they have to curtail some of their activities. Lots of note writing, writing everything down, whereas instead of just occasionally writing things down. Now, if you identify mild cognitive impairment, being aware that not all MCI progresses to dementia, depending on what study you look at and what their exact symptoms are. About 10 to 20% a year will progress every year to dementia. That means 80 to 90% will not. So you might be capturing very early Alzheimer's, or you might be capturing something else. What are those something else's? Out of control diabetes, metabolic syndrome, such as hypertension, hyperlipidemia. We do occasionally see the low B12 in my clinic, sadly. Usually it's low B12 and Alzheimer's. I'm seeing a patient, they're worried about their memory, and often they do have a dementia by the time they get referred to our clinic. But every once in a while, we can identify a completely reversible factor and other things that you see listed there that we'll talk about. So, for example, there are a lot of medical illnesses that are down here that can cause the brain to not do as well. And of course, as a geriatrician, I think about this a lot, and I'm really privileged to work with my neurology and geropsych colleagues to teach them about this as they teach me about brain MRIs. So this is a good example of an interaction of brain and body and renal disease and cognitive impairment. So this is one review of just how prevalent is cognitive impairment in renal disease. One study states 10 to 40%. Some other studies would say it's higher. Um, there's no specific guideline for screening, but some would say, people that have kidney disease should probably be screened for memory loss or cognitive impairment, just like you would for maybe an older adult, like with a MOCA or a slums exam or something. Um, so what causes cognitive impairment in renal disease? Some of the causes are the same as everyone else. Vascular disease. If someone's having renal disease because of diabetes or hypertension, they're very likely having those same diseases in their brain. But there's specific problems unique to renal disease that you might see. So if they're on hemodialysis, they might get more cerebral microbleeds, and that's something you're only going to pick up on a special kind of MRI. Uremic metabolites, anemia, and proteinuria are more common in this group that can contribute to or exacerbate cognitive impairment. So, of course, the management might be a little bit different than someone without renal disease. You're going to still treat their traditional vascular risk factors, make sure they're on an ACE or an ARB to treat their proteinuria. So, kidney transplant. Sometimes we see referrals for our clinic. If someone has kidney disease and cognitive impairment, what sometimes we get the question, is there cognitive impairment due to their kidney disease, in which case a kidney transplant may treat it? Or is it due to something like Alzheimer's, in which case it will not? And sometimes it's tricky to sort those out, but there are ways. Of course, avoiding polypharmacy, careful dosing of medications. And then really just this paper advocated for a very holistic approach. Of course, important for these patients as well as everyone to get good sleep, have diet advice, frequent visits to their doctor, and making sure their cardiologist knows what their nephrologist is doing and that kind of thing. So this same kind of approach can be applied to so many other diseases, and I just picked a couple more out. Of course, I'm an internist, so I could go on and on, but diabetes and cognitive impairment, that could be a whole hour talk, of course, given my specialty of research. But up to 20% of those over 60 years old with type 2 diabetes may have actual dementia. And their mechanisms I kind of listed here. COPD and cognitive impairment, another example. So a meta-analysis of 14 studies revealed that about 32% of patients with COPD seem to be affected by cognitive impairment. And 1 in 4, so 25%, actually had an official diagnosis of MCI. And then in addition to the normal risk factors, they specifically have hypoxemia, potentially sleep apnea, a history of smoking potentially, and maybe a real difficulty exercising because of their shortness of breath that leads them to unique causes and problems with cognitive impairment that other patients might not have. So again, when we're dealing with people with comorbid conditions in this population, it's important if we identify cognitive impairment, that holistic, non-siloed care, good geriatric principles for all adults at risk. And this is hard sometimes because, their cardiologist is at Swedish and their pulmonary docs at Virginia Mason, or they're at Kaiser, or they can't get the records, or so it can be challenging, I think, sometimes to know who's doing what. But I think it's just, if you identify a patient with cognitive impairment, it's just really critical that everyone knows what meds are, like, who's prescribing what. So this is a good time to we can peek at the chat if there are targeted questions. But summary part one. So just again, not all cognitive impairment is dementia. So when we talk about mixed dementias or just mixed pathologies, what we're going to get into in a minute, there may be dementia plus non-dementia causes of cognitive impairment. So cognitive impairment is a true geriatric syndrome. It's important to do a good exam, history labs. We're going to talk a little bit more later about meds, but ruling out delirium, excellent care of chronic medical conditions, and continue to do that if you diagnose Alzheimer's. If someone has Alzheimer's and out of whack diabetes or out of whack COPD, that's not going to do their Alzheimer's any favors. So let's see, are there any pressing questions for part one here before I move on to part two?
Diane was actually asking about that slide from Blazer et al.'s study on cognitive composite score based on age of measurement, and was asking if that could be based on age of education because, for example, some elders left school at fifth grade to work with family on the farm or land.
Yes, good question. And I have to admit, I don't know the ins and outs of this study as well as I should. Most cognitive composite scores are controlled for by education already. So these would be controlled for by education, but of course it's still going to be, higher or lower. So yes, the reason someone may have a low score is very much because they have, didn't finish high school or whatnot. I think the point of this is just to show the huge variability in, what is normal aging. That's a really hard thing to say. And if somebody didn't finish high school, that doesn't mean they're cognitively impaired once they get 70 years old because they can't say, sesquipedalian on that vocab test. You have to get more creative with testing, I think. I don't know if I answered your question, but yes, usually when you're looking at cognitive scores, you do control for level of education, if that makes sense. Any other questions before we move on to actual dementias?
I don't see any in the chat.
Okay, so what are the most, so if we're talking about mixed dementia, what dementias can mix together? So what is dementia? Dementia is cognitive impairment that you've detected from history taking and cognitive assessment. It's a decline from previous level of function. So that's distinguished from, say, lifelong learning disability. It's interfering with your ability to do stuff. So you can't work anymore. You can't play bridge anymore. You can't manage your meds anymore. You can't drive anymore. You've excluded delirium. You've excluded major psychiatric disorders as the cause of that. You can't do the thing. And you've distinguished it from normal aging. So, it's kind of tricky. And then usually we also identify a disease in the brain that is the reason for all the things, like by an MRI or something. So that's when the dementia comes in. You have the clinical diagnosis and then you get a pathological diagnosis. So what causes dementia? Now, when I give this talk to the residents, I make them guess what's number one, and I have this blank or whatever. So, number one, Alzheimer's. That's the number one cause. So I tell my residents and kind of put it in there for older adults. If you're wondering what it is, it's probably Alzheimer's. Number two, vascular. Number three, Lewy body, aka Parkinson's disease, dementia. So those are the top three. So I teach my residents and fellows, if you can identify these three diseases, you're good for most everything. Maybe we'll get there. There's other things to know about. We're going to spend a little bit of time talking about late. This causes me anxiety. I am not going to lie. This is a kind of emerging pathology that's been there forever, obviously, but we're kind of learning about it now and describing it now. And it's late stands for limbic predominant, TDP-43 encephalopathy. And if you think that's a mouthful, imagine your patients having to say that to a clerk at the store. Like, what do you have? I have limbic predominant TDP-43 encephalopathy, ma'am. Like, no one's going to say that. And if they say I have late what? So I think it needs to be renamed, but that's just me. Frontotemporal dementia, alcohol-related dementia, are other things you may encounter. Of course, this is not an exhaustive list. There are a lot of rare causes of rapidly progressive dementias and things, but I think that has to be a whole separate talk. These are the common things that you're going to see all the time. But as we're going to talk about, it may be that older adults have mixed, they have one or two or three of these things in their brain at once. And things may not always match up. We do as best as we can to make a clinical diagnosis. We get a history, we ask about symptoms, their age, when did everything start? And then we try to do a pathologic diagnosis, and sometimes they match up and it makes sense. Sometimes we're surprised. And I think part of the reason why they don't always match up is because there's mixed pathologies and because there's also concomitant diabetes, COPD, things that are affecting the brain that are below the neck. And so we have to be thoughtful and thorough about how we're making diagnoses and caring for patients. Now, it used to be that the pathologic diagnosis was actually made by a pathologist. More and more, we're seeing that we can make these diagnoses in either blood tests or fancy imaging, fancy amyloid imaging. There's even a skin test biopsy now for Lewy body. So this is a rapidly growing field, which is it's exciting but kind of stressful to try to keep up on. So we'll kind of talk about that as we go. So diagnosis of Alzheimer's. I said this is the most common. So plaques and tangles are the pathology, extracellular amyloid plaques, which we can identify in amyloid PET or LP, tau tangles, which we can identify on research imaging or by a blood test. Probable Alzheimer's disease is rare unless is rare if you're under the age 60, unless you have a very familial, like your mom had it in her 40s, not grandma had it in her 70s. Meets criteria for general dementia. So first you have to diagnose dementia, and then you have to look for the clinical criteria. So Alzheimer's should be insidious gradual onset over months to years of amnestic of cognitive impairment. So decreased learning and recall. Short-term memory loss. Can't remember where I put stuff. Can't remember words. Repeating things over and over. That's the usual case. And on MRI, you usually see medial temporal lobe atrophy, including the hippocampus. And I just mentioned above, we can diagnose this now with amyloid in the brain. So here's an MRI. On the left, there's a normal brain with a normal hippocampus. This is a coronal section, MRI. You don't need contrast. You can just get a stroke protocol with images through the hippocampus, and this is what you see. On the right here, we see severe atrophy, kind of just more atrophy overall compared to this. And then we see this hippocampi, and that inferior lateral ventricle being much smaller and this space being much bigger. Vascular dementia. So I learned in medical school way a bunch of years ago that vascular dementia is this stepwise progression. And I think that's true if you have a major stroke. So if you have a major stroke in a certain part of your brain and the next day you have cognitive impairment that stays, sure. And that's not hard to diagnose. I think what's much more common is people have this very subtle buildup of vascular change, and they look a lot more like Alzheimer's. It's more gradual and progressive, but it may affect different domains. So these are the ways you can get vascular dementia, large vessel strokes, or all of these like criteria that you have to go and add up. I think what's helpful is just to see it on MRI. So if you get a patient MRI, CT too, if you get an MRI report that says chronic ischemic white matter hyperintensities, how many of you seen that on a report? Literally everyone. Look at it. I really encourage you to look at those flare images. I have a chronic ischemic white matter hyperintensity. I get migraines and I have like one little ditzel that's like this. Okay. The rest of my brain is clean. Phew. This person has a lot more. So it really matters how much is there. And so a chronic ischemic white matter hyperintensity report can be like one ditzel or a ton. And we aren't there yet where we're getting it's like there's a way to grade this, like grade 1 through 5. And I think in the future we will get grade 1 through 5. Like 1 is hardly anything and 5 is really, really bad. But for now, you kind of have to look at them and see, like, this is probably a grade 4 or something. If you have a ton of white matter disease, that's probably enough to cause cognitive impairment. If you have one ditzel, it's not. And then everything in the middle is kind of squishy. Sorry if that's not like a super easy way to proceed, but that's, white matter disease is tough because it's not localized to parts of the brain. But you can get dementia from just white matter disease and nothing else. I've seen it. So Lewy body dementia, these are the consensus criteria from 2017. So fluctuating cognition with pronounced variation in attention and alertness. So that's almost like they have delirium and then they don't. Recurrent well-formed visual hallucinations, often of people or animals. And these do tend to respond better to the choline boosters like donepezil. So it's important to know if they are having these. REM sleep behavior disorder is actually a core criteria now. Has been for a while. And then Parkinsonism features. So bradykinesia, tremors. So Lewy body dementia or Parkinson's disease that develops dementia. These are how you diagnose that. The pathology is Lewy body inclusions. It used to be, again, you had to wait for a pathologist to see your brain, but now this skin biopsy is becoming available, and we're doing a couple of these in our clinic, and so I guess we'll know, as studies come out, how accurate it is. There are also imaging studies you can get that look for dopamine uptake. And then their cognitive testing is going to be a little bit more different than Alzheimer's. They're more impaired on attention, executive function, visuospatial, and clinically, these look quite different. Frontotemporal dementia, of course, we see it a lot at memory brain clinic because we're a big referral center. It's a little bit rarer in, in a geriatric clinic. But if you see younger patients, if you're seeing like 50 and 60-year-olds, you may see this. It's as common as AD in younger patients. So the mean onset of of FTD is 58. It's more familial. And there's two main variants, behavioral and language. So PPA, primary progressive aphasia. So people may have heard about Bruce Willis. His diagnosis is PPA variant of FTD. And the behavioral variant FTD is the most common form of all these things, and the criteria are listed here. So behavioral disinhibition, apathy, loss of empathy, compulsive behavior. The neuropsych profile tends to be executive function problems. I would say like one thing to just be skeptical of new onset mood disorder in older adults. If you have someone that's 55 and they all of a sudden have what you think is bipolar and they've never had that in their youth, think about a dementia. It could be bipolar, but just be skeptical. And the diagnosis is kind of in the name. So frontotemporal dementia is frontal and temporal wasting, and it might often be very asymmetric in the MRI. And you get relative sparing of the hippocampus. So their memory might not be too bad, but their frontal lobes are having trouble. I'm going to pause just for a minute because I've covered kind of the three most common forms of dementia. If there's any questions on those three common forms, I can quickly answer those before we talk about this nightmare.
So Diane was actually asking about sundowners. Is that considered a common form of dementia?
Yeah, so my understanding is sundowners is kind of a generic term for a symptom of dementia where you're kind of fine in the morning and then in the evening you just have more symptoms. So I don't think that that's kind of how I think about sundowners is it's a side effect and any type of dementia can get that, but I definitely think about it being more common like Alzheimer's and Lewy body where you just your sleep-wake cycle is altered and morning is okay, but nighttime you're just not okay. I don't know if anyone else has something to add.
Richard was wondering if there's any evidence that vascular changes at the cellular level is the major common factor in all dementias.
Good question. We're going to get a little bit into that when we talk about mixed dementias, but Alzheimer's and vascular have very similar risk factors, and so it may be that that's why they share um they share pathologies, so it may be that's why they co-occur a lot. Um
And let's see. Diane is also wondering about the skin study you mentioned. Is there any way that she can get more information? Um, Diane, I'd suggest that you email the Northwest GWEC email, NWGWEC. I'll put that in here. Um, and we
yeah,
can send
I
that
know that
along.
one neurologist in our clinic is doing skin biopsies for Lewy body. I think it's just very new and it's not always covered by insurance. So I would say it's very experimental and probably done by like specialty centers like ours. But for right now, I mean, if you're worried about Parkinson's disease or Lewy body, I would, refer them to a neurology clinic.
Good point.
Because not only for diagnosis, but also for management,
Mm-hmm.
especially Parkinson's, because those medications are really complicated. Like I even feel out of my league with Parkinson's. So
Maybe.
late. Okay, can we? Yeah, I
Oh,
think.
I'll hold these until more towards the end. Then there's a
Okay,
couple others.
yeah. So late is this is the diagnosis I said a little bit earlier causes me a little bit of anxiety. And the reason why it causes me a little bit of anxiety is it's a mimic of Alzheimer's. It's like Alzheimer's, but you can't really diagnose it. And it's just um it's a problem. So, but it's a part of our universe now, and so I think we have to deal with it. So like I said earlier, It's its acronym is LATE and it's limbic predominant age-related TDP-43 encephalopathy. If any of you have heard the term hippocampal sclerosis, this is probably the cause of most cases of that. So what it is, it's a protein, it's an RNA binding protein that's similar to tau, but it's not tau. And they found it in some FTD cases. So a lot of these FTD cases that I talked about before, frontotemporal dementia, that also co-occurs with ALS, these are tauopathies, except for a few people who had FTD, but it wasn't tau. It was this protein. It was this weird protein. But then they started looking for this weird protein in Alzheimer's, and they kept finding it and finding it, either co-occurring with Alzheimer's or occurring without Alzheimer's and just looking like Alzheimer's. And I'll show you that on a slide. So what late is it's really an Alzheimer's mimic. If someone has just exclusively this protein in their brain without plaques and tangles, they have problems with memory, but it's less dramatic. Their age of onset is typically 75 or older, and they have a more indolent course. But Alzheimer's could do all of these same things. You could have an Alzheimer's patient that presents at age 75 that has a mild memory loss and has a more indolent course because they're just healthier or whatever. So this is why I said this causes us anxiety. And the diagnosis is similar to a lot of other neurodegenerative diseases in the past, officially only on autopsy. But unofficially, and this is a rapidly changing field, this was a big plenary session at Alzheimer's meeting last year in Philadelphia. There are hints of ways that we can maybe separate out what's late and what's Alzheimer's and what's maybe mixed of both. If you have this elevated inferior temporal lobe MTL ratio, sorry, I should have put that's on a FDG PET scan, a scan you're probably not all ordering on the regular, and they're amyloid negative. Um, then you probably have this late diagnosis instead. And I have to say, I have quite a few patients with this. So I have a handful of patients who we diagnosed Alzheimer's, and like 3, 4, 5, 6 years later, their MoCA score has dropped like 2 points. So I'm like, we should test you for the amyloid, and they're amyloid negative. So they're amyloid negative, but they look like Alzheimer's. So I think they have late. So this is a paper. You can see at the bottom here, 2025. I literally got an email about this from Dr. Fisher this morning. So I am not kidding about this is like we're all trying to deal with this like right now. So this is hot off the hot news. This is a flow chart how some of the experts in this field suggest that you might deal with it. So if you have a progressive amnestic syndrome, so if you have someone that looks like you think they have Alzheimer's and you think they could have Alzheimer's by themselves, they could have Alzheimer's plus late, or they could have late by themselves. Does that make sense? And so um I guess Alzheimer's by themselves isn't quite on here. Um, but if you're worried about them having either one, so um this is kind of a flow chart that they're recommending that we do. And it's, of course, it's very biomarker heavy. So if you have severe hippocampal atrophy that's no more than mild dementia, out of proportion, you might have both. If you have severe hippocampal atrophy, but you don't have amyloid, then it's probably just late by itself. So a lot of people are a lot of smart people are putting together guidelines and trying to help us all out in these kind of dementia referral clinics to help us understand. And I'll talk a little bit later about what do we do in primary care with this information, because obviously not everyone has access to amyloid PET imaging in their small clinic in rural wherever. But I just wanted to let you know kind of where the thinking is going. And just a little aside here is that, as we're using these anti-amyloid therapies, if your memory loss is due to the combination of amyloid and this other protein, and you're only removing amyloid, then it may not be as effective, right? If you have this other protein, or if this other protein is just along for the ride, treating amyloid still might be okay. So there's a lot of unanswered questions, uncertainty, grumbling at meetings. We're all staying tuned for this late diagnosis. Just a quick slide about alcohol-related dementia. So, this is another topic that could be like its own hour-long talk, but just a quick little slide about it. According to a couple of reviews that I've read, about 78% of patients with alcohol use disorder, so, for, a long time that, have it for a while, have some type of brain pathology. And the brain pathology that's the most described is prominent white matter loss in the prefrontal cortex, corpus callosum, and cerebellum. So I guess in thinking, I probably should have put this um, with the vascular slides. It's kind of a more vascular kind of disease rather than like tau and plaques and things. Similar to vascular disease, but in a different pattern. But you do see atrophy and neuronal loss, more in the frontal lobes, hypothalamus, and cerebellum. So not in the same parts that you see in like Alzheimer's disease. Now, why does this happen? Lots of different theories. Alcohol itself is neurotoxic, also causes thiamine deficiency, i.e. Wernicke-Korsakoff syndrome. And then there's a lot of confounders in this population, similar to how Alzheimer's, what we thought was Alzheimer's, can be heterogeneous because of late. Vascular dementias can be heterogeneous. Alcohol-related dementias can be very heterogeneous because of head trauma, history of seizures, vascular copathology. If they have hepatic encephalopathy, that can cause a whole other mishmash of cognitive symptoms. But the cognition profile is somewhat preserved semantic memory. So they can name things, they can do category fluency, they can do all the verbal memory stuff. But they're impaired in visuospatial. It tends to be more in the back of the brain. Working memory, motor speed from the cerebellum, executive function, so that from the frontal lobes. And they have a lot of anterograde amnesia. So you hear about the confabulation of Wernicke-Korsakoff's. And it may be reversible in early stages. And really, so if I see a patient where I think this is a real big problem, my focus is abstinence, abstinence, and abstinence. I don't try to put them on donepezil. I don't try to do, anything else. I really try to get them off alcohol and use, addiction medicine and other things to try to do that. And make sure they're on thiamine and B12 supplementation. while you're trying to get them to that point. All right, so summary part two. So those are the core features of the common dementias. Imaging is particularly useful for Alzheimer's and vascular. I mean, MRI is how you diagnose vascular dementia. It can definitely help with Alzheimer's. Late and Lewy body, it's less clear. People in very early stages of the disease, unless it's vascular, their MRI might look kind of normal, so you just want to be careful. The history is obviously a very important piece. It's important to assess cognition. And biomarkers are here for many things. Others are coming fast. Others we're still kind of waiting for, like late and whatnot. But I'm going to do a few slides about the mixed dementias and how they're all mixed together in autopsy studies. And this is a good time to take a couple of questions, if there's any more. See them? Oh, I can see them. Oh, we're going to get into cholinesterase inhibitors. We don't know if cholinesterase inhibitors help. Clarification, please. Is there a correlation of both sporadic and familial ALS? Okay. Substance. Okay. So, I'll take, so, just really clear, there are a couple of, so frontotemporal dementia tends to be more likely to be, familial. And there's one gene, one of those genes can cause FTD and ALS. So you'll have a family and like a brother might have ALS and his sister might have FTD. And then in other family and other genes just cause FTD. But if you're worried about someone having FTD, you do want to ask about FTD and ALS. I hope that was kind of clear. Is there a correlation of both sporadic and familial? So there's one gene that I don't exactly remember. It might be ORF that can cause both familial ALS and FTD. Now, ALS can also just be completely sporadic and not related to genetics. So I hope that clear. I hope that's as clear as mud. Where does substance abuse come into play? I mean, obviously, substance abuse, including things non-alcohol, can accelerate vascular disease. So those would be a part of any good medical history taking. Okay. Well, we will get into cholinesterase inhibitors if we have time. Okay. Mixed dementia. This is what I was supposed to talk about. But when I sat down to do this talk, I thought, I think it would be good to just talk about like all the things that can affect our brain. So we're finally here. I think when we talk about mixed dementias at meetings, like if you go to Alzheimer's meeting and you go to a talk about mixed dementias, what they mean is what pathologists see on autopsy. And I think what this talk has hopefully been about is mixed reasons to have cognitive impairment. And I think that's a much broader topic than mixed dementias. But when people talk about mixed dementias, what they're talking about is when you take someone's brain and put it in the lab and cut it up and stain it, you see a bunch of stuff. So the bottom line is it's very common to have co-pathologies in the pathology lab. And the most common pathology is Alzheimer's plus vascular, or depending on other studies, Alzheimer's plus late. Alzheimer's plus Lewy body, or all three or four. Some people have everything because they want to have it all. And it's more common with age. If you look at 60-year-olds, they're potentially more likely to have one pathology. If you look at 80 or 90-year-olds, they're probably more likely to have more than one. One study that I read suggests less than 30% of dementia is pure AD. That means 70% is not, right? That's a lot. That's a big number. Now, the limitation of this is when we're talking about this, these are all from autopsy studies and people over their 80. So if you're seeing a 60-year-old, does that still matter? How do you factor that in? How do you think about that? And how do we process that information? So just a little bit more detail. So an NIA study showed that 94% of patients that were diagnosed with Alzheimer's, 54% of them had a coexisting pathology. Um, they didn't look at the late protein, but they did find vascular was number one and Lewy body was number two. A different study from the Mayo Clinic Brain Bank, a majority of AD cases had coexisting pathologies. Comorbidities they did increase in frequency with age. Common co-pathologies, the percents weren't exactly given, but the frequency just went up with age. Um, One thing to know is vascular. When people say vascular pathology, when they're looking at pathology in the brain, that's very heterogeneous. So we see white matter hyperintensities and strokes on MRI, and that's kind of what we see. They can see more stuff because they have the vessels and they can look for all kinds of funky stuff. So pathologists can probably find more vascular disease than we can. And so that's probably why that's probably why they find more of it because they have the vessels in their hands and they can see it. So they find small vessel disease, large vessel disease, cerebral amyloid angiopathy. That's another thing that gives me anxiety and worries overnight. That's when your vessels have a lot of amyloid and they're more friable and can bleed. Lewy body inclusions are things that are seen by pathologists. And then, of course, late pathology. A Rush study, this was a Rush study that specifically wanted to look at that late pathology, so that TDP43 protein. They looked at 946 older adults, 398 had dementia. This was two cohorts combined. One of them was the religious order study, which some of you might be familiar with. Average age 89 at time of death. So again, these are older people. Those with Alzheimer's, 66.2% co-occurred with this protein. That's a lot, don't you think? 54.4% co-occurred with arteriosclerosis, and then 34% co-occurred with Lewy bodies. TDP43 pathology was present in almost two-thirds of those with clinical AD dementia, being the second most common pathology after a pathologic diagnosis of Alzheimer's. And we can just see that in a graphical form. On the left is no dementia. So people that died and had no dementia also got autopsied. And people without any pathology is the white. People with some pathology is some in here. So people with no dementia still had some pathologies. They just didn't have dementia yet. And then people with dementia, here's that purple is ADP, Alzheimer's plus late, or TDP43. So again, a high percentage of individuals with this stuff. So hardly anyone has just AD. And again, when we're thinking about using these AD treatments, it's important to know. I did find one study that looked at mixed dementia by ethnicity. This was a little bit of a smaller study. I believe the number was 122. It's in my comments. They looked at African Americans and Caucasians, and they did show in this smaller study, but African Americans did have more, they were more likely to have mixed dementia, even when controlled by age. They were more likely to have, so like pure Alzheimer's is the blue. So the pure Alzheimer's is a little bit smaller pie here compared to the Caucasian group. And then people with Alzheimer's and infarcts is here. People with Alzheimer's Lewy bodies here. And then people with all pathologies is this big red. And then that's just a tiny sliver here. So just more mixed dementia in this group. Of note, TDP43 was not assessed in this cohort. This is from 2015, so not quite on everyone's radar yet. Let's see what time at 40. I'm going to go ahead and talk about what do we do with all this information in our clinic, because this is a lot of pathology stuff. And then hopefully we have plenty of time for questions. So what do we do with all this? You know, I think if we have somebody in clinic and we're worried about a dementia diagnosis, I think that making a formal diagnosis of a dementia by clinical history and then trying to figure out if they do have any of these pathologies, either with MRI or fancy referrals to our clinic or stumbling through, these different tests. MRI obviously can do a lot of the work, but it's important for these reasons. Identifying vascular disease is important because you can identify vascular risk factors, treat those. If you identify CAA, if people are at risk for CAA, they have increased risk of bleeding and they should avoid things like taking NSAIDs all the time. Um, Everyone should avoid head trauma, but they should really avoid head trauma, if they're falling and things like that. I think Lewy body dementia is a diagnosis that should never be missed because the Parkinson's aspect really does change the management quite a bit. This late stuff, if someone has pure limbic predominant TDP-43, and they really don't have amyloid, they may have a less worse prognosis. And that just may be something the family needs to know or wants to know. And then, of course, if someone is really interested in the anti-amyloid therapies, they have to have amyloid in their brain to get the disease. So for a variety of reasons, patients and families may want to or need to know what pathologies are in their brain. And, if you're seeing somebody that's younger, they may have just one. If you're seeing someone that's much older, they very likely have more than one. And mixed dementias and being comfortable with saying, you have a little of this and a little of that. I get pretty comfortable with saying that over and over. And then just to be just to be mindful of all those other conditions they have on their problem list may be contributing to their intermittent delirium, their medical conditions, their poor sleep. So I think it's still important, like I said, to establish neuropathologic changes. The younger they are, I think the more important it is, but brain MRIs, history and exam. It's important to screen for and manage reversible causes always. I do this every visit, review their meds, chronic disease management. And I believe by and large, for the most part, except for maybe, I should have put this on the slide, sorry. Except for frontotemporal dementia, where I think there's data where these meds really don't do anything and may cause harm. Alzheimer's disease meds have been shown to benefit Alzheimer's, Lewy body, and off-label vascular. And when these Alzheimer's meds were studied, late wasn't even looked at. So 100% guarantee that some of those patients had late. People that were in the donepezil and memantine studies had mixed dementia, right? They had to have. Rush told us that. So if it worked in that mixed population when we were ignorant about late, then go ahead and try. So this is why do I say that? Because they act on the choline receptor, and the cholinergic receptors go awry in a lot of these diseases, irrespective of whether it's tau or TDP-43 or amyloid. It's kind of affecting the same brain structures. So you have choline, you have acetyl-CoA, you have the synapse. Here's acetylcholinesterase. When you have the system working, acetylcholine binds to the receptor and sends a signal. So your procholine drugs, like donepezil, they inhibit breakdown of acetylcholine, allow improving neurotransmission. Whereas anticholinergic drugs like Benadryl, Detrol, amitriptyline are competitive inhibitors of acetylcholine and block the neurotransmission. So you can just see that donepezil and anticholinergic drugs like Benadryl literally fight and are enemies. So it doesn't make sense to be on both. I really try to get my patients with dementia off of these anticholinergics as soon as possible. And you can't always do it. But the anticholinergic burden index is a good place to start if you aren't sure. Drugs with the score 2 or especially score 3, like your amitriptylines, your dizipramines, your oxybutanins, scopolamine patches. And most of these drugs, thankfully, have better alternatives anyway. Amitriptyline, there's SSRIs. Oxybutynin, there's better bladder meds. So thankfully, none of these are like life-saving and required by law to be on. So the FDA oral approves meds for dementia. I tell my patients you can call these choline boosters because acetylcholinesterase inhibitors is hard to say. So your donepezil, your galantamine, your rivastigmine, they boost choline in the brain, and I think there's a place to try those in almost all of the dementias I've talked about, except FTD. And memantine is even more nebulous what it does. It's an NMDA receptor antagonist, glutamate regulator, so it might help many of these dementias as well because they're not specific to the tau or amyloid or Lewy body pathology. They're stimulating the brain. So, if you want to try them, the way I try them is I do a trial, I check in 2 to 4 weeks, and if they don't seem to be doing anything or causing harm, we stop. So, summary part 3 and 4, mixed dementias are very common, particularly in older people. Leading pathologies, in addition to Alzheimer's, are that AD mimic, TDP-43, vascular changes, Lewy body changes. Mixed pathologies may affect diagnosis, prognosis, management. Okay to diagnose lightly over time, order testing if it changes management. But the bottom line is a lot of these dementias can be treated similarly. Try the AD drugs, manage comorbid conditions, manage what matters most. There are some key exceptions that I kind of talked about. FTD is kind of its own thing. You might send a genetics counselor. They aren't going to be helped by AD drugs. Um, they are different birds. Lewy body has its own different meds. But for the most part, you manage these different conditions. Naming it helps the patient, but you kind of manage the same anyway. And now I hope we have time for questions. Thank you so much for your attention, and I hope I didn't go way too over.
Well, that was excellent. I really appreciate the very up-to-date information about late.
Oh my gosh, like literally this morning.
Yeah.
I'm like, oh my gosh, I got to throw this in my talk. I mean, I had a bunch of other slides about late, but that exact paper with that slide was in my email inbox this morning.
A question occurs to me that might come up from others, and that is you had mentioned neurology. Is that who you'd recommend folks go to for maybe a suspicion of a mixed dementia or perhaps someone with Alzheimer's that there seems to be a change or somewhat different from what they were understanding Alzheimer's to involve? So
Yeah,
would
that's such a great question. And it's funny you should ask that, because next week our Memory Brain Wellness Center is having a retreat and we're going to be discussing like what should our referral center focus on? Because we are, as you may or may not know, we are a 6-month wait to see patients. So we can't possibly see everyone with garden variety Alzheimer's. Like we have to decide as a group, like what should we focus on? Who should we see? Um, and what should and all clinics are like this. I go to Philly and Boston and these different towns, and every clinic like us is struggling with the same exact problem. Is there's so many people out there with this huge need, cognitive decline, cognitive impairment, and memory clinics such as ours, like what should we be focusing on? And we all may have different opinions. I don't think there's a right answer. Like if I could clone myself and see patients 4 times, right? I'd see every old person I could. Um, but here's what I would say. I think that referral to a memory clinic or to a neurologist is really important for a couple of things. Number one, if it's a rapidly progressive dementia, and what I mean by that is they were normal a year ago and now they meet criteria for dementia. So those are red flags for something really serious like you know, cancer in their brain or Creutzfeldt-Jakob disease or, some of the kind of rarer things that neurologists learn about. And I hardly ever even see those. But um, Hashimoto's encephalitis and those scary things, viral encephalitis, things like that. So if you're worried about a rapidly progressive dementia, um, and or they have a lot of neuro symptoms or seizures or things like that. Those are kind of easy to refer to neurology. The other time I would say, like, when do you refer kind of, a dementia patient to a memory clinic? Well, if they want lecanemab, if they want the anti-amyloid therapies, that's kind of a requirement because I don't think other places are giving that. And then the other time would be is if you really are unclear about the diagnosis, if it's real and the diagnosis would really change management. So people are still working and they really need that diagnosis for like getting on early Medicare. So if you are 50 and you have dementia, you can get on Medicare, but that kind of takes a special, set of things. So early onset, those kind of things. And then, yeah, early stages, so mild cognitive impairment, and you're really not sure, like, this person um, needs neuropsych testing. They're maybe still driving. They're still trying to manage a bunch of finances, families pulling their hair out. I think if the diagnosis is really going to change a lot of management, there's a lot of ethical questions about their IADLs, that kind of thing. Those are the kind of patients that I think um, you know, can be really tricky to manage. If they have established Alzheimer's in kind of the moderate stage and, you can get by with social work resources and the diagnosis is not that unclear, I think that's, not as crucial to refer when the diagnosis is probably Alzheimer's or probably Alzheimer's plus vascular. Their MRI shows a little atrophy and a little white matter. And what you really need is a social worker, and the family really needs to hear about like how to get them in assisted living. Hopefully, we need more social workers everywhere because memory brain just cannot see all those patients, and they just won't be seeing all those patients because we just can't. So we would love to. It's not that we don't want to. But yeah, I think when the diagnosis is in question and because some people might not actually have dementia, you know. So I think those are kind of the keys. Sorry if I'm going on.
No, but it
But
actually made me wonder.
yeah.
So, do these mixed dementias usually co-occur, or is there a sequencing that you might really see and diagnose Alzheimer's and then something else, or vice versa?
That is such a good question. That is such an excellent question. What I've seen happen a lot is when we take care of people, especially when we're identifying people really early, I think some things start to pop out on us. Like I've had quite a few people that seemed like they were Alzheimer's, and then they started showing their true color Lewy body a year or two into the mix. And so whether it's they didn't really have much for Lewy body and they started developing it or they had it the whole time. Um, I think you're absolutely right. If you're dying, if you're I mean, obviously these things don't all occur all at once. If you fall autopsies to the terrible joke that pathologists like to say is autopsy studies are the ultimate cross-sectional study, right? Like they're only identifying the people when at one time point in their life, and they're literally cross-sectional of their brain. So we don't know. Like you don't know when did that person develop late and Alzheimer's and Lewy body. But I can say just from taking care of patients that it is true that as I see people go through time, sometimes they do look like one thing and then they start looking like something else. I've had a lot of people that I thought were Alzheimer's and then they started looking like Lewy body. So they probably have both. And that's the importance of, we don't, at our clinic, we diagnose and we check on patients every 3 to 6 months until they don't want to see us anymore, which is another reason why I think it's a great care model. Some other places like us, they diagnose and then they're done. So they can potentially see more patients, but they're not caring for those patients over time. And I think that's kind of a terrible model personally, just because so much of what I do is caregiver teaching, management of all these things. But it means that we can see less patients. So there's kind of like benefits and burdens to both. But I definitely see people develop them. Another thing that I've seen, probably the most common, so Alzheimer's, and then they show their colors of Lewy body, is people that I think have vascular dementia. They come in, they're in their mid 60s or like 71. They have vascular MCI. They don't have much for hippocampal atrophy, and their memory's okay. And I follow them and follow them and follow them, and then like they're 78, and their memory is just bad. And we get a repeat MRI, and okay, now we think they do have in fact, Alzheimer's. So,
Interesting.
just because someone didn't have Alzheimer's at age 71 doesn't mean they won't develop it in 5, 10 years. So yeah, you got to keep on your radar, keep checking for stuff. But you don't have to check for it every year, which is nice. These things are slow.
So, Hom from Toronto, and I hope I'm pronouncing your name correctly, asked if you have any experiences with Indigenous patients with dementia in your geriatric and clinical practices.
Yeah, we do a little bit. Some of the other providers have a lot more than me, because they go out to those communities. So like Dr. Demoda Riley, and there's some outreach centers that go to those places and give talks and things like that. But I would just say at Harborview, we have a big variety of people from just all over. But I personally, like, I don't think I see enough Indigenous patients to have kind of like a knowledge base of it where I can say this is what I've seen here or there. But there is definitely some hopefully knowledge that's being built at our center and other centers. There wasn't much for mixed dementia studies in any group that I could find other than the African American one that I did. There were a couple in China that I did look at, but I tried to focus just because this talk was already, I knew it was going to be already be so long, um, that I focus on studies that were predominantly in America. But it's a much needed it's a much needed area of study for sure.
So, we'll let other questions that might evolve, but I thought I'd pose one of these sort of interprofessional questions to ask the attendees. What dilemmas, if any, have you encountered with mixed dementia in your settings? And maybe let us know your settings where you have encountered some of these. Maybe, Angela, I can ask you to step in and talk about what settings are patients with mixed dementia. Are they still pretty much at home, or are they in other settings that you see?
So I see Mayhash Stetler,
Mm-hmm.
care coordinator, PHN,
Public health
um,
nurse.
public health nurse. Great. Thank you so much for the work that you do. I see people with vascular more than anything else. Yeah, so, oh, patient health navigator.
Oh, patient health now. Thank
We
you.
just totally made up an acronym for you.
Yeah.
Patient health navigator, also amazing. Thank you. Um, yeah, vascular. I mean, as an internist, like I'm first and foremost an internist, even though like people think I'm a neurologist most of the time. Like, I love talking about the heart and all the vascular risk factors. And I sit down with my patients and I just say, here's the deal. I'm going to talk to you about some really boring stuff, and I am so sorry. But there's some really cool stuff you can do for your brain, and exercising. That's probably the most studied. It's better than donepezil. It's better than anything else. You know, get out, throw those supplements away or don't, but buy some really good running shoes, walking shoes, and get out there and walk. Like that's the best money you can spend. Those supplements, and so I basically give them this kind of pep talk about exercise and diet, and it sounds so boring. It's like Hippocrates wrote about this in 500 BC or whatever. Like, but it's still so true. And I tell them face to face, like, I need that pep talk too. I'm giving it to myself. Like, um, so yeah, so people with alcohol use disorder and drug use disorder. So yeah, if people have quit drinking and using drugs, I mean, I just or quit smoking. I just tell them like that is one of the best things you've done for your health. We can keep you at bay, and just encouraging them to keep at it with their health. Like okay, you quit smoking, you quit alcohol, but your blood pressure's high. It's really important that you take this blood pressure medicine to keep that brain healthy. And um, so they have that investment. Um, Mixed etiology that really includes those alcohol, difficult to treat symptoms. So geriatric ARNP in a long-term care setting, mostly adult family homes. They're seeing an increase of people moving into adult family homes with dementias, many undiagnosed and mixed. Yeah, so the undiagnosed dementia is definitely something that we see a lot when I work on the trauma service. I do a lot of dementia diagnosis in my clinic, and then when I take care of the geriatric trauma service, people come in from all over the state or even other states, that get flown in from Alaska or wherever to have their fancy surgery, and they very likely have dementia that's been undiagnosed, or, oh yeah, they have whatever old timers disease, and it's just never been identified and named. And I think it's just so critical for patients and families, even if they don't get the fancy test, or even if it's just on a CAT scan, like some is better than none, to name the diagnosis and say you have this neurodegenerative disease, and it's really important that your family is aware of it, manages it, and weaves it through your care plan. If you have diabetes, you shouldn't be on a really complicated insulin regimen or like warfarin 2.5 every other day and five every. No, like it gets too complicated. Like simplify the meds, please. So that's something that I try to do when I see a patient on the inpatient side, if they have undiagnosed dementia, like make that diagnosis and make sure it gets followed up on. Brain health exercise packets through the Goodwin Institute. We'll have to look into that. We kind of have our own little, everyone has their own little handouts and
Right.
stuff.
But May, if you have a link for that, that would be very, very helpful. Not sure if it's proprietary or not. Another question I was going to ask everyone is um, Angela mentioned need for more social workers and interacting with social workers. Um, what what kinds of interprofessional interactions, or who are you working with when you are addressing mixed dementias or trying to support patients and caregivers management of these mixed dementias?
Yeah, that's a good question. I think there's kind of two-fold approach to that. One is if somebody has kind of a mixed cognitive impairment with dementia and a lot of comorbid medical conditions. So that's kind of the first half of my talk.
Mm-hmm.
So the mixed dementia plus diabetes, dementia plus COPD. I really try to work closely with their primary care doctor, and make sure they have kind of a coordinated care plan. So, do they have a primary care doctor that is kind of mindful of geriatric prescribing? Do they have one prescribing doc or maybe just two? Like I do one set of meds and they do the other.
Mm-hmm.
Um, and making sure that everybody knows what everyone else is doing. So, having a good, solid primary care provider that kind of is a good conductor
Mm-hmm.
of their care, I think is really key. And sometimes they have a social worker or was a
Or a
health.
patient health navigator.
I was just scrolling up. The patient health navigator embedded in that system is great because memory brain wellness is just a little bare bones clinic. And so we don't have the time as much to follow up with people with all their things. So if they have a lot of comorbid medical conditions, I think I really rely on like good, just solid primary care.
Well,
And
the
then
other
the other, I'd say with mixed dementia, I think the other thing I really rely on is the just um maybe more frequent visits with patients and families, and just um showing them their brain. and really just giving them information and not being a little bit afraid or not being afraid of that, a little bit of uncertainty,
Mhm.
and I just share with my patients like, hey, I'm not really sure which pathology is causing you the most problems, but here's a couple things that we can do right now today to treat your memory, and I want to help you feel better. I think we can help you feel better because I hear that you're depressed. And I think an SSRI would help you, and that is going to help everybody, And so, um, really partnering with them and, keeping it kind of simple in that way. And if we see people a little bit more frequently and target those, again, that what matters most, I think that's helpful that rather than focusing so much on just like a diagnosis. Like you have a
Mhm.
memory loss disorder. And what I heard from you today is mostly about your depression. We're going to talk about that and then
Yeah.
do that.
Yeah.
So really focus or falls or whatever it happens to be. And you can do that kind of without knowing which diagnosis they have.
Mhm.
I mean, I do think it's important to identify that there's something going on, but then it's also okay to kind of not be sure too, if that makes sense.
Yeah. I was also wondering about because I know we have a lot of these professionals attending this series, things like uh, with Lewy body physical therapy, occupational therapy, speech therapy, those kinds of referrals or interactions. To what extent does that seem indicated?
Yes, absolutely. We absolutely refer a lot of our patients to speech therapy, physical therapy, occupational therapy. So unless someone is really, really impaired, and can't follow directions, then that might be difficult. But speech therapy can be really helpful early on in a course of disease, especially if their caregiver goes. And speech therapy at that point isn't so much curative, but to help with workarounds. Like the families learn workarounds for FTD or aphasia.
Mm-hmm.
And then physical therapy for anyone with Parkinson's or Lewy body is evidence-based and I think grade A evidence.
Mm-hmm.
100%. Oh gosh, a dementia diagnosis is really life altering. Do you have suggestions on how you deliver the diagnosis? I mean, I will kind of want to say, invite me back. I'd love to give a whole talk on that. I think, the way that I approach it, I set aside a visit. Of course, I'm at the Memory Brain Clinic, so we have the luxury of having like 80-minute inpatient, or sorry, 80-minute consultations and then 40-minute follow-ups. We actually have family conferences sometimes, where I deliver the diagnosis and then we have a social worker and a nurse practitioner roll out a bunch of stuff. But for patients where they don't have that family conference, if I'm delivering the diagnosis, um, a lot of times they know already because their MRI's been released to them beforehand, because of the Cures Act. But they come in, I make sure everyone's there, and I say, I like to just start out right off the top and say, unfortunately, we did show your MRI did show changes that are consistent with dementia. And I let that kind of sink in because I like to just do a spoiler alert right at the beginning. And then we look at the MRI. I spend a little bit of time I don't let people go into what are we going to do? I force a little bit of like, does everyone understand this diagnosis? Because I think, what are we going to do? And me prescribing Aricept in the first 2 minutes really cheapens the visit and it doesn't give patients and families a chance to grieve a little bit and ask questions. I talk about like, I wish I had better news, but I'm hopeful that this gives you and your family some answers and knowledge is power. So depending on what the situation is, I pull a lot of different phrases and things and comfort, of course, if there's a lot of sadness and, I just pull from my palliative care skills, hopefully, um, to deliver bad news. But once the family and patient has had a time to process, and again, we pull up MRIs and look at them together. And a lot of times the families in our clinic, because they come to us for the thing, they're not that surprised. So, they want to know what to do.
Mm-hmm.
So And then I say, this is a journey. There's a lot we're going to talk about and do. But today, let's focus on a couple of key things because you can get overwhelmed with so many things. And then I try to do a lot of patient-centered stuff. If the families are talking, I try to look back at the patient and say, your family is wanting you to start medication. What do you think? So that's just a couple of key pearls. I'm sure I could talk a lot more about that, but yeah, making sure they have enough time to grieve in the visit, making sure they look at we look at MRIs together, whether it's on Zoom or in person, and then uh, trying to set a couple of goals for that visit and trying not to overwhelm them with too much all at once. Say, this is a journey. We're going to start here. Oh, the other thing I was going to say is, and I wish I had it handy. I'm in my home right now, but how many of you are familiar with the Washington State Action Plan and the Dementia Roadmap? So,
We're actually
actually,
going to have some coverage next week, I think it is, where
oh yeah, I have that right
Chris
here.
Rhodes is going to be talking about
Yay! Oh,
that
I
as
see
a
it on here.
foundation to
This is,
developing the new state dementia.
I swear this
Um,
was, I'm not a plant for Chris. But no, okay, this is great. So all of you that are on, so the Dementia Roadmap is one of my favorite tools of all time. The last page of the Dementia Roadmap has all three stages on it of dementia. It's mostly kind of built for Alzheimer's, but it has like um mild, moderate, and severe dementia. So this is invariably what happens. If anyone has, like, I guess we have a couple. This is invariably what happens to me, and it happens not just at like the disclosure visit, but it happens like on visit 5. I've been seeing these patients for a while, and let's say they kind of start progressing a little bit, and we're talking about this and that and the other thing, and then I have like 2 minutes left of the visit, or I'm running late. That's never happened. And the daughter will say, "Hi, can we talk about the prognosis and the plan for the future and like what to expect and all the things?" I have like 1 minute.
yeah.
I'm like, no, we cannot. You got to get out of this room. I got 5 more patients. I mean, I don't say that, but I say, oh my gosh, I'm so glad you're here. This is such a journey. And so I run and get the dementia roadmap. I'm like, I wish I had more time with you today, but this is a good place to start. This is my crystal ball, and this is kind of where we think we're at. And let's set aside some more time to talk about this. But I think I've had that happen so many times where it's just like the families, I try to set up like what they want to talk about at the beginning of the visit, but sometimes I feel like it just doesn't happen quite. Visits can go sideways, and then the family is like, can we just talk about all the things? Like, can we talk about the meaning of life in the last minute of the visit? Like, no, we cannot. But
I
the
really
dementia
like
roadmap.
your approach, though. It's a really nice approach because it's sort of integrating both the caring and the comfort and the support along
Yeah.
with information and preparing for the next steps, that kind of thing.
Yeah, I say a lot of things, and patients don't always remember what they say, but hopefully they remember the spirit. So I use a lot of humor. I use a lot of like, I'm so glad you're here. I'm glad you feel safe. I'm glad we're here talking with you and your family, even if they're kind of upset. Like, I feel safe at home. I'm fine. Like, I'm so glad you like your home, even though we kind of want to move you out of it. Like, um, but yeah, the dementia roadmap is fantastic. I'm glad you're going to hear about it. And if you don't have 100 copies, go grab some and hand them out because those are really helpful. And that's Lisa Andrew uses it all the time. So
I
thank you
suspect it
so
will be
much.
on their slides, but if not, I'll throw it into the chat next week. Sorry, I don't
Yes.
have it readily at hand.
And please feel free to evaluate me. Any suggestions are helpful. Evaluations help us in the academic world for promotions. So, and also just I would love evaluations and feedback just for my next talk. So thank you so much.
Thank you. This was just outstanding. I really appreciate all of the information. Everyone, thank you for attending, and I will see you next week.
Great.
Have a nice evening. Thanks, Angela.
Yeah, thanks for having me.
Just great.